Thank you, Professor Blivus, our session chairperson. My name is Huiling Ong, and I'm a fifth-year medical student from the University of Glasgow. And today, I will be talking about a study that was conducted to assess the impact of regional MDTs on the management of complex urogynecological conditions. Just a little bit of background to our study. In 2019, NICE guidelines recommended women who were thought to require complex surgery for urogynecological conditions to be discussed at regional multidisciplinary teams, and articles postulating the benefits and disadvantages of this followed. However, no robust evidence could be found regarding the efficacy of MDTs, and there were no universally accepted standard of MDT care to follow at the time of the study. So we collected various data with the aim of obtaining an indication of the efficacy of MDT decisions, its impact on patient management, and the time taken for resolution of the condition. All patients from the west of Scotland who fell under these complex categories were referred to the MDT. And throughout this MDT's existence of 5 years, it saw 60 patients. The key figure to note on this slide is that the inclusion of an MDT discussion certainly did prolong the time between the first presentation and the resolution of the case. But this is in particularly if video urodynamics were required, implying that MDT scheduling may not be the factor causing delays, but rather the availability of video urodynamics. This slide shows in some detail the patient population under the care of this particular regional MDT. Of the 60, it's worth noting that changes were made to 25 patients' original management plans, which makes up 41.7%. And within these 25, 14 were surgical plan alterations. That means almost 1 in 4 patients received a different surgery from the initial suggestion by their surgeon, and this was usually done due to safety concerns. For example, the team would have chosen less invasive intervention compared to the individual referring surgeons. Just over a third indicated an improvement in their condition 3 months post-treatment, and none of the recorded outcomes were worse off compared to pre-treatment. Unfortunately, 23 women were lost to follow-up 5 years later due to various reasons. However, this does seem to appear that at least 36.7% of women had a good outcome. Despite the relatively high loss to follow-up, our results still showed the positive potential for multidisciplinary teams. A significant impact was made on healthcare provided to these women. Women were offered a wider range of alternative treatments and were able to undergo less invasive alternatives that had overall good outcomes. Our study demonstrates regional MDTs are in fact feasible and showcases the advantages of cross-sharing of resources between hospitals within the one region. While our data may be regarded as historic, it offers valuable lessons and provides a model for future regional MDTs as recommended by NICE guidelines. A prospective study with contemporaneous data collection of complex presentation discussed at a regional MDT is important to assess patient outcomes, particularly in the long term. We further recommend that a parallel qualitative study needs to be done to explore patients' view on MDT decisions and their clinical outcomes, which will then provide us with a more accurate picture of the impact of MDT decisions. Thank you so much.